Okay, we're live. I think everybody can see it now. I'll say hello, everyone. Depends on your time zone. Good afternoon and good evening. Welcome to MedLink's exclusive webinar series, which we call MedLink Global Rounds. Today, we will explore ADHD together. I am Ren, CEO and founder of MedLink Global, and I am so honored today to host this special event featuring two distinguished experts. First, allow me to introduce my co host and moderator, Dr. Christoph Correll, one of the most influential minds in psychiatry and psychology worldwide. Professor Correll ranks among the top 0.1% of psychiatric researchers and has made groundbreaking contributions to this field. Joining him is Dr. Paul Hammerness, a renowned ADHD expert and author who has devoted decades to research, teaching, and clinical care. His innovative work has transformed our understanding of ADHD treatment in both kids and adults. Today, they will share their insights on managing complex cases together across different age groups, offering valuable perspectives for healthcare providers, researchers, and patients. So now, hand over to Dr. Crow to start the session.
Great, thanks so much, Ren. Thank you all for being here today. Well, the complexity lets us stumble not only over the word, but many of these cases. And we're really delighted that you're joining us. And I'm delighted to be joined by Paul Hammerness, who is one of the experts in ADHD care. So you're in for a treat discussing three paradigmatic cases, but also answering your questions. Paul, why don't you take it from here?
Thank you very much.
Let's get the slides up. Yes.
There we go, and we're off. So we're going to be talking about ADHD today. You can move on to the next slide. So attention deficit hyperactivity disorder, or ADHD, is a very common illness really across the lifespan. You see here numbers that describe high prevalence, high frequency of ADHD in children, adolescents, and adults. Those are US numbers, but over the past decades, we've realized that this is a condition, of course, that occurs worldwide. We know this is a highly familial condition. It runs in families. The risk of having ADHD appears to be driven by whether your parents and grandparents and cousins have ADHD more than other factors. The research is ongoing and really has become remarkably collaborative, I would say, too. Christoph, you agree, across the world, trying to understand with big sample sizes what the genetic contributions may be. In terms of ADHD,
so maybe you want to also highlight the complexity that these symptoms bring into people's lives.
Absolutely. So ADHD can appear in different ways. So it's a heterogeneous disorder. For some, it's mostly about lack of focus, trouble with organization, completing tasks. Others, it's largely about hyperactivity, impulsivity. This is often what you see in the young children that present with concerns. And ADHD itself, in the absence of treatment, is really associated with a whole range of deficits. And I think that the research in the past couple of decades on ADHD in adulthood has really emphasized that the impact can be across sort of all life domains as compared to sort of the past view, which was much more about school functioning. The realization that ADHD can impact someone whether they're in school, work, their relationships, impact their safety, their ability to adhere to basic healthcare, to be organized enough to go to the gym on time, et cetera. So as compared to the general population, ADHD confers risk in a whole range of areas that impact people on a day-to-day basis.
And that even includes having more automobile accidents, premature mortality. Actually, untreated ADHD is also associated with more substance abuse than taking stimulants, which can be abused by people who don't have ADHD. And that's often a fear and a barrier to installing the treatment of ADHD, but it's the reverse. When you don't treat it, you're more likely to self-medicate, correct?
Correct. All right, go ahead to the next slide. So primary care and pediatrics is typically where issues first present. So parents bring their child in and have concerns about academic or behavioral problems, symptoms of inattention, hyperactivity, impulsivity. It's the expectation, according to the American Academy of Pediatrics, that pediatricians, family medicine, et cetera, are asking about ADHD symptoms and are asking about them in a structured fashion. And so to make a diagnosis, the questions, and we'll show you a rating scale too. There's a way of structuring that, the questions and the information that you can collect from parents, guardians, teachers, the child is seeing a counselor, et cetera. So it's a series of questions asking about the presence of these symptoms. And the expectation is if it's significant, it's going to occur across settings. It's not just going to be in reading, or it's not just going to be at swim lesson. It's going to be really across the person's whole experience for kids, for adolescents, for adults. And then referrals can go on to specialists, which can be child psychiatry, depending on availability, because there's only several thousand child psychiatrists in the country. It could be to neurology, developmental pediatrics, but primary care is often where these issues are first discussed. And there are structured ways of approaching the diagnosis, which is a clinical diagnosis based on information collected. It's not a brain test or a blood test or a paper and pencil test. So next slide, you'll see an example of a rating scale. This is called the Vanderbilt, and it's a rating scale. You see on the top there, it says parent assessment scale. So this is what the parent would fill out based on symptoms across the child's given week. And then you can hand in the same form that has a teacher heading on it to the teacher, collect both those. The pediatrician will collect both those. Oftentimes specialists may get the same information too, and take a look at how often these symptoms are impacting the child's life on a day-to-day basis. And you see the areas of inattention, the specific concerns around trouble paying attention, completing tasks, some of these organizational abilities as one type of ADHD expression. And then you see the hyperactivity, impulsivity. You also see within impulsivity that being hyperactive and impulsive can affect how someone expresses emotions too. There can be sort of a hot temper that can go along with someone, particularly younger kids with significant impulsivity. They can be impulsive in their kind of their emotional expression. I don't know if you see that as well, Christoph.
Yeah, absolutely. And what's very important in fine print at the top is that it has to be appropriate for the age of the child. So yes, kids that are 2 or 3, they are hyperactive. They are somewhat impulsive because they can't express themselves with language yet. But as we mature, we should be able to control both our motor output, our focus, and also our impulses and emotions. So it's not like, because often ADHD is seen like as a vogue disease, or we're trying to make children into functioning soldiers at school. This is not what we're talking about. There is obviously always in life a bandwidth, and people can be different ways. But these are symptoms that are not just symptoms. They become a syndrome and a disorder because there's either personal suffering or problems with functioning. That's always how DSM and ICD define a disorder. So yes, everyone might see in their kids or in themselves some of these symptoms, but as they become more and become clinically relevant, we could then talk potentially about ADHD. And it has to be in more than one setting. Can't just be at home or at school or with friends. It has to be at least 2 settings.
And that's the role of the provider, provide that feedback. Sometimes, families will come in as the first child and they're wondering, is this norm, or is this something I should be concerned about? And that's where you get information from other settings, including teachers, where they say, hey, this lack of focus, this forgetfulness is really impacting your child's ability to learn. And then you can see it impacting social interactions as well. So this is one piece of information that is collected during an assessment for a child with ADHD.
Maybe just one more point. Often the point is being made, but when Johnny plays his video game, he can concentrate for 3 hours. So you can't just take one isolated thing where you have a lot of dopamine going because it's so much fun. It's about whether you can pay attention when it's somewhat boring, when you're distracted easily, or when you basically can concentrate for 5 or 10 minutes, but then it's totally gone. This cliff we see in patients who have ADHD, and that's also a signal that you may want to pursue that further.
Yeah, agree. Yeah, it's really about regulation of attention than it is simply never having it.
But let's go into the cases. We have only like 15, 17 minutes left.
Yeah, let's keep moving along here. So, and just to say for adults as well, this is a clinical interview. Many children will continue to have symptoms of ADHD across their lifespan. Sometimes it's missed, and so some adults may not realize they have a disorder and will come in their 20s, 30s, 40s asking about ADHD, and we'll talk about that in one of the cases coming up. All right, next slide. And then I think a final intro to say that there's a lot of literature, a lot of research being done in ADHD, but at present there's not a evidence-based prediction model. You can't say to a given child, adolescent, adult, this is exactly the kind of medicine you need, this is exactly the kind of treatment you need. There's an opportunity for us to try to do our best to personalize treatment, but there's not something we have at hand right now to predict what will be best for a given person. All right. So we have 3 cases we're going to be talking about. Ethan, age 9, the parents are asking, why don't medicines work for him? Gabriella, 16, is it inattention or anxiety? And then Michael saying, I'm told it's depression, but I think I might have adult ADHD as he comes in at age 30. So first off, we'll talk about Ethan. So for Ethan, concerns about his hyperactivity and impulsivity began in preschool. The moment he came into like a social context, preschool teachers were saying, hold on a moment, this is not the typical expression of activity or excitement. And parents say, you know, he was unsafe in public. They would be concerned about him. He'd step out of the car and dash right away from them. Almost had injuries, that degree of impulsivity and hyperactivity. So 3 months into kindergarten, because of concerns about his inability to sit in circle time, start working on some skills, be safe in the playground on the swing set, the family came into the pediatrician and described symptoms of ADHD in some depth across all settings, and they completed that rating scale that also reported this whole range of symptoms that were occurring on a day-to-day basis. And based on that extensive assessment, he began stimulant treatment at about age 6. But the parents are coming to us now as experts saying, we felt like it was the right path, but the medicines didn't work. So next slide. So first of all, is this the right diagnosis? If there's a lack of treatment response, that's always the first question, is backing up. All right, let's talk about ADHD again. Let's collect the same history again. Let's ask the same kind of questions. Let's take a look at rating scales, and let's be convinced this still appears to be a collection of symptoms really consistent with ADHD that occur across settings. And then importantly, think about other confounds. Think about other factors that might impact a lack of response to treatment. Is there a sense that there is a specific area, not in Ethan's description, but for some, child is really struggling with focus just in reading or just in math, but not in any other areas. That could suggest a learning disability specific to that area. Or there are other symptoms of depression that appear to be even more concerning than ADHD or anxiety. Or there's significant autism where there's a real disconnect in terms of social listening and social interactions that appear to be the primary issue for a child on a day-to-day basis. And then because ADHD runs in families, parents will admittedly say, I have ADHD, my son does it, and boy, is it a chaotic home, and no one's organized and no one's going to bed on time. And that is not helpful for a child's ability to respond to treatment. Nor could there be, you know, if there's stressors or changes in schedules by parents. So there's a number of factors that are always important to explore when you're considering someone who might not respond to medicine. All right. We'll keep moving along. So we'll get a little more information next about the medicine trial. So one of the also very good pragmatic questions is, did he take it? Kids are not always skilled in taking medicine. Um, Back in the day, it was typically just one form of medicine, but now there's a whole range of forms of medicine that allow kids to be able to take them more successfully and consistently, which is so important to be able to understand how do they tolerate it and does it work. So there are sprinkle capsules that you can open up and sprinkle on a spoon of applesauce. There's liquids, there's patches that allow consistent and confident use of the medicine to really judge how they're doing. The other questions besides just did he take it was things that include how old was he, what was the dose that he took, how big was he at that time, how long did he take it, and when you get into the details here for Ethan, his first trial was when he was young. He was barely 6 years old. It was a small amount of medicine, but he got moody and teary and different from his normal self, and they stopped it within a couple weeks. They waited for another year or so and decided to try it again. At that age, he was still not a big kid, not a big weight, and so the dose they started on was relatively significant for his weight at that time. Didn't eat well, and they stopped it after a month or two. So we have some potential factors here to consider. Next line. Next slide. So in summary, Ethan had a really convincing ADHD history, went back over it. He had symptoms across all contexts. There was no doubt about that. Turns out the more that the family talked about ADHD, the more they realized that actually mom had symptoms of ADHD and there was a cousin who had ADHD. So there was a greater understanding of ADHD that was running in this family. There were not significant psychiatric confounds. There was no additional anxiety or learning issue for him. But when you get into the details of the medicine, and it's always important to take a really good, thorough medicine history, it appears there were some limitations there. That makes us think that trying another medicine, a similar medicine, again, makes a lot of sense. Young children may not tolerate them the same as older children may. The dose matters in terms of tolerability. And if it's a short amount of time on medicine, it certainly may not be enough time to gauge how well it works. And the side effects can impact treatment response. And I assume that rings true for you too, Christoph.
Yeah, so this is such a typical case that there is the illness, one sees the impact, and then the medication is somewhat, first of all, danced around. Do I really need this for my kid? Is that good for their brains? Not thinking that maybe the illness also impedes brain development and social and academic development. And then the medication is tried just a little bit. And once there's a stumbling block, it's being given up very early without trying to fiddle with the dose, finding a different medication. They're not just stimulants, they're also non-stimulants. They don't have the effect size, but for some patients, it's the only thing they can tolerate. And we can even combine medications. Now, this is obviously specialists talking, but just the message is don't give up too early and hand over your kid to this illness that will make it hard for that kid, not only to develop well and have social interactions, but also self-esteem. You're always the guy or the girl who's either withdrawn and doesn't get it, and people laugh about them, or who's the clown, or who's just overactive and disturbing. That does something to how you see yourself, even as an adult.
Yeah. So next line. This feeds right into the comprehensive recommendations. So recommendations. These are broad recommendations, and then some, specifically for Ethan. So always about education, always helping people understand what ADHD is, always education about basic self-care. Sleeping, eating, exercise are critical self-care habits, oftentimes are not done well by kids and often adults too. So always good to repeat the importance of consistent sleep routines, eating habits, exercise habits, talking about social activities, face-to-face social activities like the old days, some management of electronic usage, so that's not taking over. And then to Christoph's point, we're really trying to build self-agency. We're not medicating children. We're providing medicines to help kids feel like they have more control of their ability to focus, more control of their behavior. I'll often say to little kids, hey, how big is the pill? It's small. How big are you? Look at you. You're working hard. I think the medicine's helping, but boy, look at what you're doing. So it's really to build agency. It's not to take you away. And it's critical to model healthy ways of talking about medicines, whatever the medicine is for children. Thinking about school advocacy for Ethan, he didn't need specific services for learning disabilities, but many do. And then consider what I call skill development areas for young children, maybe social skills groups around turn taking and management of impulses in a social milieu, like a group of other children working on these areas. And then oftentimes, as you get into middle school or older, having some executive functioning organizational skill development can be very helpful as compared to like the classic therapy for an anxiety or depression. And for Ethan, as Christoph says, again, these were short trials, young age, go back to the first line medicines, start out a lower dose, gradual increase, making sure you're monitoring eating, weight, and effect. And if there's tolerability issues, you can think about non-stimulants as well. So this would be sort of a comprehensive approach to talking about medicine treatment for Ethan. All
Just
right.
one more point from me in terms of school advocacy. Sometimes what's sufficient is to just move the kid from the back in the room where because they're disturbing, are moved to the front, and also move them away from other kids that talk to them and that they're not so distracted. And that can really help the focus. Very simple method.
All right, so we'll move on to our teenager. So 16-year-old Gabriella, inattentive from childhood. They called her Spacey Gabby. She was also shy in elementary school, didn't speak too much, not a lot of friends or activities, but more academic concerns in a middle school, was losing things, had zero sense of time, according to parents. She admitted that was very true. Grades started declining. Anxiety started building into high school, really to expand beyond academics to include worries about friends, future, disappointing others, and the family saying, how do we help her be focused and less anxious? Next. So adolescents really can report nicely on their own experience, and school functioning is typically the number one concern, not only because of academic growth, but it's also their social settings. We want kids to be successful in that context, so that's usually where I start. And I ask about their own self-experience. I say, all right, Gabby, you're sitting in English class. Can you visualize where you are, what it's like, who the teacher is? Now tell me, you're not paying attention, right? She says, no. Is it because you're thinking, is it raining? What's for dinner? Or is it thinking, I'm going to mess this up. My parents are going to be so upset with me. And often adolescents are like, that's me. Or no, that one's me. And he said, all right, so day to day, and Gabby said, day to day, she's just random stuff. She's not full of worried when she's sitting in class. So then the conversation is, well, all right, so if you were more focused, would you be less anxious? So if we treated you for ADHD, would you be less anxious? She's 100%, because then I would be focused in class. I wouldn't be concerned about the end of the day. I wouldn't be regretting and anxious about all the things I missed. So anxiety, attention, it can be a whole circular loop, but we're looking for a place to start. And for Gabby, next slide, it was pretty clear that day-to-day in school, it was her inattention. That was the place to begin. We talked about stimulant class medicine, educate that this does not uniformly worsen anxiety. It could improve it indirectly if they're more focused and have some greater self-confidence. So 2-3 months later, response, clear improvement in focus, clear ability to get more work done, increased academic self-esteem, but now also the emergence of very clear generalized worry, not in her control, impacting her sleep, impacting her ability to go out and social. So then it leads to another conversation about evidence-based treatment for anxiety disorders as being the next step. And this can happen for a child coming in with a primary area of concern. Over time, with ongoing surveillance, other areas can emerge, and that was the case for Gabby.
Yeah, comorbidities are not infrequent in kids. We should bear that in mind.
All right, and bearing our time in mind, we're going to stay organized, and we're going to move on to Michael, the whirlwind of ADHD across the lifespan. So this is 30-year-old Michael, and he presents after several antidepressant trials over the past 5 years without improvement. And this is not uncommon to hear from adults coming in for an assessment for ADHD. Otherwise healthy, successful, young family now, has done well in sales, but he's got an administrative role and is really struggling to keep up and balance home and work. He ends the day feeling demoralized. about forgetfulness, inability to complete work because of his efforts, failed efforts at multitasking, and says, I don't think I'm depressed. But I really do feel bad about myself. I don't feel as successful as I used to feel. I feel like I'm failing in a lot of areas. Next. So is there a history of ADHD from childhood, even if it was not earlier diagnosed? And he recalls childhood. He brought in an older sibling who was quite happy to talk about all the trials and tribulations of his childhood. He was a bright kid, did well, successful, but would lose things absolutely. Left coats on the bus, made the family late. They always had to say, Michael, look at me. They just, all the narrative, all the stories came out of his childhood once he started understanding what these symptoms were. They were quite clear. He recalls cramming and drinking caffeine drinks to try to study at the 11th hour to get through high school. That's how he survived college, putting things off, procrastinating, and then just cramming at the 11th hour with a lot of caffeine. He again felt confident when he was primarily doing sales, but now he's got more of a desk job with a lot of administrative paperwork to do and children, and he's really struggling. So next. So yes, ADHD began in childhood. There's a clear narrative that he's able to provide as we provide education about the illness and with some collateral information from family. But he was able to compensate over time. So for him, impairment increased over time, while for others, it can decrease over time to some point where he was at threshold and it was really impacting him on a day-to-day basis. So for him, as with others, psychoeducation about ADHD, understanding how this may impact home, work, relationships, understand that there's some increased risk of his children to have ADHD and to be aware of that. We talked about discontinuing the antidepressant, and he said, well, he's been forgetting it so often, it's not even in his system and it's not relevant. So let's move on and talk about first-line medicines for ADHD for him, and just go back one more for a moment. And because of his caffeine use, as you start a medicine, you start cutting back on the caffeine. Some adults will drink a lot of caffeine, and with starting a medicine, a stimulant medicine in particular, they can feel more jittery, buzzy. So sometimes you got to reduce that as you start the medicine. It's just a little bit of an important clinical pearl.
Yeah, talking about self-medication, there's even self-medicating behaviors. I know of people with adult ADHD who've done a lot of sports, and then after sports, where we may basically get a little bit drowsy or worn out and want to relax, that's when he studied, or when these people study, because they are on. Or other people, unfortunately, then self-medicate with substances, whether it's stimulating substances or even against the feeling bad and trying to come down after being so wrapped up and feeling so much under pressure to get things done, and not feeling that they can execute their IQ. Because what's happening in effect is the ability in your brain, you can't get out into life. And that's very frustrating at times to you, also to parents, but also to partners and friends and family around.
All right. So next and final slide, and then I think we'll have plenty of time for questions. So as I hope we provided you, a little glimpse, ADHD begins in childhood, and it can be identified in sort of the beginning social experiences as kids head into preschool, as in Ethan's case, and it can continue as a chronic disorder. Its impact can vary over time, but its impact can be quite broad, from the classroom through social activities into work and home relationships, as you've seen with these cases. It's diagnosed by primary or specialty care providers. It's a clinical interview, meaning it's questions about symptoms. It's looking for other areas of concern that might be the primary focus of treatment. And the primary focus of treatment can change over time, as we saw with Gabby, starting out with inattention and then leading towards the necessary treatment for additional anxiety disorders. And personalized treatment is what we all do our best to provide. It always includes education about the illness, risks and benefits of treatment, opportunities to develop self-care skills, skill development around social skills or organizational skills, and then medicines is typically a component of that for many folks, again, from childhood through adulthood. So I hope, again, this has been a helpful review of of cases across the lifespan. And I'll turn to Christoph to wrap up, and then we can move into some questions.
Great. Thanks so much, Paul, for having led us through these 3 exemplary cases that many of the audience members might have actually experienced themselves or seen others grapple with. And obviously, there's individual differences for different people. And there's always a threshold. When should I get treatment or not? And we'll talk a lot about that. When should I start? What should I start? And when should I stop or change to something else? And we've already gotten quite a bit of questions, and I'll just read one after the other. Maybe we can start with a simple one. Can children with intellectual disability also have ADHD?
Do you want to lead off and start with?
Yeah. Go ahead.
Well, so yes, they can. Children with intellectual disabilities, with learning disabilities, can have ADHD. There's a range of intellectual abilities. The more significant intellectual disabilities are certainly going to impact more complex thinking. So it's important to understand, the degree of disability, to understand what the needs of the child may be, and the potential uncertainties around response to medicine.
Yeah, maybe this question is a little bit fueled by a change from DSM-4 to DSM-5, where previously, at least with autism, you couldn't co-diagnose ADHD, which never made sense to me. And we also use stimulants in kids that had, in addition to autism, which might make you be very to yourself and not socially interactive. But it doesn't, there might be IQ difficulties, but it doesn't necessarily come with inattention. So now it is possible to diagnose ADHD with any other diagnoses. It might be hard in people with psychotic disorders, but in general, it's really a distinct syndrome, and we should at least look for it. Again, something about comorbidity. So let me see, that was here. How to distinguish symptoms such as inattention, impulsivity, hyperactivity, disorganization, and mood disturbance is often seen in complex PTSD from those associated with a primary diagnosis of ADHD, considering the overlapping features and underlying mechanisms of each condition. And we should say that obviously people can also have traumatic experiences and ADHD at the same time. What's your answer to that, Paul?
Yeah, that's an excellent one. And certain populations carry more exposure to violence, trauma, upheaval, etc. For me, what I'm looking for is the sort of the core experience of ADHD, meaning lack of focus or impulsivity. And so for a child who is just at their core, just sort of pulled to the environment, just distracted, just at baseline, not in the presence of a stressor, not at the time of an anniversary of a loss, not in the context of a recall of a traumatic event, but just day to day, relax at home, spacey. So I'm looking for that. Or conversely, for the hyperimpulsive kids, living in this high energy, go, 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 constant movement, bringing that kind of energy regardless of moments of stress and reactivity. So sometimes you'll see some kids where around stress, reactivity, a flashback, and exposure to violence, you see surges of behavioral discontrol, more consistent with a PTSD versus sort of living in that space. I guess maybe that's a way that I would think about answering that. I don't know if you have other ways of thinking about that, Christoph.
No, I think very well described. We have so many more also case histories. I'll leave it at that. But it's still, again, about diagnosis and something about the third case also. So what criteria do you recommend using for screening ADHD diagnosis in an adult, especially when childhood symptoms are not properly documented?
So in the past, just 2 decades, adult ADHD was discovered, and there was a tremendous amount of research and work on that, and some efforts to translate scales into more adult-specific language. One of the slides had a reference to ASRS, and if you look up ASRS or NYU or WHO, you'll find that. It's a language that's more specific to adult ADHD. It's that, and then in the case of Mike, it's thinking about collaterals too. It's not uncommon for people to have notes from elementary school, report cards, still alive parents, cousins, etc., who can recall what it was like to grow up with you. So don't forget to reach out to other folks.
Yeah, and also, even if it's not documented, you can ask the people, obviously. But there's another lengthy description which I think delves into exactly this, and also having an overlap with Michael as our third case. So hear me out. I have had many cases in which the consultation begins with young people who have finished high school and have migrated to go to college in the city where I work. So that's a care provider. We have a couple of parents also chiming in later. Since their adolescence, they had suffered moderate problems of depression and recreational substance use. After the first year of university, they show a great collapse with a strong increase in substance consumption and depression, devaluating and failure in their study project and in emotional relationships. After 1 or 2 years of treatment of the depressive condition and changes in habits and working on personal history, a clear ADHD condition appears. In such dirty cases, in terms of history and symptoms, when it has not been detected before in childhood and the mood deterioration and comorbidities permeate the entire current picture, are there signs that could improve access to an earlier diagnosis? Is it common to lack a response to treatment with methylphenidate in those cases, or to limit the dose due to adverse effects? And the last of the three questions, so one is that what are signs to give it away? What's the treatment response in such cases? And is adolescent depression considered a consequence of childhood ADHD or a great concealer of the underlying diagnosis?
So there's a lot in there. The description was a very nice description of a clinical approach. Here are people coming in, they're struggling, there's depression, there's substance use, there's a sense of treatment response, and then there is more of a clear narrative of ADHD that is remaining still following the successful treatment of the depression and the substance use. So that was a nice description. Even with that, I suppose there are cases where it's not as clear to recall the symptoms in childhood, but you have a clinical picture that is most consistent with ADHD. There's no other explanation. So then it may be quite reasonable to begin a medicine and see a response and see if the response is specific around improving cognition, processing, restlessness, and not just I feel better, I have more energy, which is not a therapeutic response.
Right, and I think one point that we haven't made is that 2/3 of people that are kids with ADHD will have it into adulthood, but often the hyperactivity goes away. What stays is the emotional and cognitive impulsivity, and also obviously the inattention, but it's not as visible as someone who's dashing around the room. And in terms of treatment response, I mean, we now have good data that adults who were untreated as kids can also respond quite well. And the symptoms and signs would be the ones that we're looking for in general. But it also has the substance abuse history. So another question was, so what would you do in someone who has substance abuse disorder? Would you treat them for their ADHD, and how?
That's a tricky one because there's a whole range of substance use disorders, right? There's some, what is relatively common cannabis use. And then there's more significant now illicit drug use, cocaine, et cetera, OxyContin. So I would say it depends on the degree of impairment and the degree of substance use disorders. I would always aim to treat the ADHD because it may drive substance use in some cases, as you were discussing, Christoph, earlier on. But while thinking about the potential misuse of the first-line stimulant medicines, you may choose a non-stimulant medicine as your drug of choice for someone with a significant substance use disorder.
Great. So we have two more case-based questions which go into similar directions. What do I do instead of medication? Can I stop? What's the way of communicating this illness for my kids? So I'll go through them. My 7-year-old kid has a high IQ, 141, which is really high, and also diagnosed with ADHD 1 year ago. But I don't want him to take medication. Well, he has an illness. Would you say that if he had basically asthma, would you not treat him? But you know he has asthma? I believe there's a better way to manage. Well, stimulants have the highest effect size of all medications we know in medicine. 0.8 to 1.2. This is 2 to 3 times as high as general medical condition medications, whether it's psychiatric or non. He can play Lego for hours. That's the phenomenon I described before. When something is fun, you don't lose your buffer that you don't have to spend on things that are boring, but he's not able to sit for 5 minutes. I also noticed that he has no empathy, never had long-term relationships with classmates, friends, and is not kind to his sister. Outside the home can suddenly become very excited for no reason. Well, that's the impulsivity. But why not treat him? How do I manage his behavior, especially in public places, such as during events, if we do not want to use medication? Or how do I find a minimal medication intervention? So here, we see this so often, it makes me edgy and hyperactive and impulsive myself. You see the impact of the illness, but then you say, oh, but maybe the medication could have an impact. And you're weighting something against your kid by not at least trying to treat. Will it always help? No. Could there be side effects? Yes, but at least try it out. And the fear of the illness is so much smaller than the fear of the cure for the illness. So anything else you want to add to this?
What I often say too, is I mean, always search for other opportunities. Make sure that they're sleeping well, eating well, getting a lot of exercise. Search for active ways of engaging socially, sports, swim, etc. So absolutely try to burn the energy, engage them in ways that are going to be positive, that they're really excited about, because that'll help them focus better. But in terms of medicines, I mean, I often will say, this is not the beginning of insulin. This is not the beginning of a lifelong medicine. This is a period of time, 3-6 months of medicine and reassessment. Kids change, kids evolve, kids develop. The aim really is to help kids develop and to be successful. So this is not you accepting a course of treatment for a lengthy period of time. That is not necessary. This is us exploring this together and reassessing over periods of time. So,
although very often when it's severe ADHD, there will be long-term treatment needed. And again, we have to weigh the fear of the illness and the downstream effects. Here, being not good to his sister, being problematic in social communities, that leaves a scar in someone's emotional and also personality makeup, which we shouldn't underestimate. And there's sometimes also the question, well, he is hyperactive. Why would I stimulate him? These are called stimulants. Are you kidding me? He's overstimulated. But it's interesting. The more you can concentrate, like reading a book, you become calm. So there's not enough concentration to actually filter all of these stimuli, the background and the foreground. And that makes kids then hyperactive because they can't process everything. So helping them to open the window to the world can really help them inside and outside to have a clearer view and also function better. Last question, it's a three-part question, but I think it's important. I'm a mother of a diagnosed 13-year-old girl. The other one was 7, a boy, now it's a girl. Here are my questions. Beyond medication, what specific lifestyle modifications, habit-forming strategies would you recommend for my daughter to better manage her ADHD symptoms and also improve overall well-being? Her symptoms are not completely under control. Should we try other medication? I think you've answered the first part, all the healthy lifestyle and maybe also school modification. But should we try other medication? If one doesn't work, of course, maybe different dose, maybe different mechanism of action, maybe even a combination. And for example, if stimulants make it hard for kids to sleep, which is really a problem, either change the medication or add another medication in the evening that is also an ADHD medication, like an alpha-2 blocker, clonidine, guanfacine, which can then take care of the side effects and augment the other effects. Second question, is ADHD a lifelong condition, or is it a possibility that my daughter might outgrow some or all of her symptoms as she matures? How does this typically progress for adolescent girls?
Well, we've talked about that. Absolutely. ADHD can can vary over a lifetime. The energy hyperactivity tends to settle, leaving more concerns typically about focus and organizational skills. So I would emphasize real attention to that. And you can start working on that when they're in elementary school. You know, put your stuff in the same place, have a sense about time, build those skills.
But on the other hand, as kids mature, the outward symptoms might decline, and then there's still the inattention and not being able to function well, maybe making decisions that are not good, having lots of accidents and injuries, small and larger. So one should also look for these symptoms. And the last one is really about self-esteem. My daughter is uncomfortable to disclose her ADHD diagnosis at school and refuses to utilize the accommodations offered in her individualized education plan, IEP or 504 plan. What approaches can we use to help her understand that ADHD is a common neurodevelopmental condition and that using available support is not a source of shame, but a tool for success?
I think that coming out of the pandemic, we've realized how many kids struggle with anxiety, sadness, ADHD. So I equate it with all these conditions. And I'll say, look, you look in your classroom, probably a third or half of the kids in your class have anxiety, sadness, ADHD. This is just one experience that is common for so many kids. So this is not about you know, not being smart or not caring or trying to be difficult or et cetera. This is something that runs in families. This is something that you most likely inherited from the family, something you can work on. You can develop skills to sort of overcome this and manage this. And so it's a lot of education and support.
Great, and it's also cultural acceptance of mental illness, and that's a broader educational path. We have 3 questions we can't get to, unfortunately. I'm sorry about that. We're already over time, but Paul, this was a great discussion. Ren, what do you think? Did it look good? Did it go down well?
Yes, I really enjoyed all the content and the conversation. We received more questions actually along the way, but you know, to all our audience, sorry we couldn't cover all of that today because limited time. But we do offer expert consultation services. So check our website and reach out if you have any complex cases need consultation from Dr. Hammerness and Dr. Correll. So, yeah, thank you so much, Dr. Correll and Hammerness, for all your exceptional expertise, and thank you for advancing care in ADHD.
And thanks to the audience for spending the time with us, and hopefully you have gotten something to take home, and we're here also to help if need be. Take care.
Yes.
Thanks. Take care.
We'll see you next month.
Exactly. See you next month for another session that we will post and publicize.
Sure.